Good morning and welcome to our audience here in Geneva and around the world on our live stream. I'm Ali Blunt with Devex Partnerships, and we're thrilled to be partnering with McKinsey Health Institute on this event and convening this critically important conversation on one of the most urgent challenges in global health, which is a shortage in the health workforce. We have a really exciting lineup here for you today, and for our in-person audience, we are going to wrap at the end with a Q&A conversation. But before we delve in, I want to introduce Dr. Pooja Kumar, who is with our partners at McKinsey Health Institute, to kick us off.
Thank you. Thank you all for being here today on a topic that is very near and dear to my heart, and I know it is to many of you here today also. Before I hand it off to our great lineup of panelists and speakers, I just wanted to say, three things that I hope you all will take away from today. The first is that the problem of closing the gap in healthcare workers is massive and it's growing. The second is that closing it will have material impacts for both health, but also for our economy globally. And the third is that this is not a problem that can be solved by healthcare alone. Let me just give you a couple numbers for each of those. So number one, the WHO estimates that there will be a 10 million person or FTE shortage in healthcare workers by 2030. 10 million is a big number, but it's also probably a conservative number. And there are a whole range of other estimates out there that range anywhere up to 80 million. The second is on the second point around this being an urgent problem. If we close that gap in healthcare workers, it would result in 189 million more years of life, healthy life added globally. Okay, and that is a massive number, which my colleague Yenli will talk a bit more later on how to contextualize that. But to make the economic case, that's the health case. It's the right thing to do. But also economically, if we close that gap, that will add $1.1 trillion to the global economy. That is equivalent to the entire economy of the country we're sitting in today, Switzerland. So it is material. And third, many of you, like many of us in this room, have been fighting this fight already, right? We're doing it already in our daily jobs. We've been working at it for a while. This is not a problem that the healthcare sector is going to solve alone. It's a problem that requires private and public sector organizations to come together. It requires healthcare, it requires finance, it requires economic development. And so hopefully the discussion today will paint more of the detail of not just what the problem is, but what we can all collectively do to come together on this. Thank you, and with that, I'll pass it to Yenli.
Thank you so much, Pooja, and it's really wonderful to see everyone here today. My name is Yenli Wong, and I'm a partner as part of McKinsey's healthcare practice. And I also have the privilege of serving as the director at McKinsey Health Institute, where I spend my time focusing on the topic of health worker capacity, primarily how we can address the global shortage of healthcare workers. I'm very excited today to be able to share more of our research on this topic. But before I start, I'd like to kick us off with a few stories. The first, recently, a woman in rural Mississippi had to travel over 90 miles in order to deliver her baby. Her local hospital was facing financial pressures and simply did not have enough staff to keep the hospital open. In the United Kingdom, many patients are being faced with lengthy wait lists as part of the NHS. And simultaneously, healthcare workers, whether they be physicians, nurses, pharmacists, and others, have been speaking up about the impact of burnout. The last story is about Nigeria. And if we think about the physician to population ratio, which is at 1 to 5,000. That is 10 times less than the ratio that is recommended by the WHO. And why do I tell all these three stories in three different continents? It's because they're all united by a single theme, the fact that there are patients out there who require healthcare but simply do not have access to healthcare workers at the right place or the right time. As my colleague Pooja just mentioned, this problem isn't going anywhere anytime soon. The WHO projects that by 2030, there will be a 10 million healthcare worker shortage. And it is on us to develop scale solutions that will address not only the supply side of healthcare workers, but also the demand side. But first, let's talk about the impact of closing this healthcare worker shortage gap. Our McKinsey Health analysis shows that closing this shortage could avert 189 million years of life loss due to early death and lived with disability, or 7% of the global disease burden. Now, those are a lot of big numbers that I've just thrown out at all of you. And to put it into context, closing this gap would be equivalent of eradicating maternal and neonatal morbidities and mortalities, translating into saving the lives of 12,000 mothers and infants every day around the globe. So there is a significant impact on health worldwide. And as we think about the global life expectancy at birth, our research shows that we will be able to add 1.5 years to global expectancy at birth if we were able to close this shortage. What's more, for countries in Africa, this impact is even larger. Our analysis shows that we'll be able to add 7 years to life expectancy at birth. So there's this significant impact on improving health worldwide. But also, let's talk about the economic impact here at play. If we were able to close this shortage, we would actually be able to add $1.1 trillion to the global economy, which, like my colleague Pooja just said, is actually bigger than the GDP of Switzerland, where we are all standing today. So we've talked a bit about the size of the shortage. We've talked about the impact of what it could look like to close the shortage. But I want to caveat a few things about the shortage itself. The shortage is not distributed equally. If you look at this bubble chart up here and you see Africa, countries in Africa right in the middle and that big bubble there. Countries in Africa make up only 17% of the global population. But the opportunity in closing the healthcare worker gap in Africa will actually drive up to 70% of the reduction in disease burden. And why do I say all of this? We at MHI believe that it is absolutely critical to understand a region's, a country's, even a city's local dynamics when it comes to the labor healthcare market in terms of supply and demand, and truly understand what your own population needs. And so if you actually think about different countries and where they fall, we have developed a framework that helps us look at how we can actually develop a path forward that works for various different countries in different places. So we have what we see here, 4 different country archetypes. The first, worker scarce. The second, worker and job scarce. The third, worker advantaged. And last, worker surplus. However, I think it will be clear to all of you here and those on the live stream that unfortunately, there does not exist a single country in the worker surplus archetype. I'll talk a little bit about each of these archetypes just to contextualize it for all of us. In the worker scarce archetype, and note these are mostly countries that are middle income countries in Latin America, Asia, as well as the Middle East. These countries simply do not have enough healthcare workers to meet the needs of their population. So it's imperative that they focus on investments in expanding the training pipeline. The second archetype, worker and job scarce. These are mostly LMICs as part of sub-Saharan Africa, and they're faced with a dual challenge. The first challenge, again, they simply do not have enough healthcare workers to meet the needs of their population. But even more concerning is that they also do not have the jobs in sub-Saharan Africa and many of the countries that fall into this archetype. So they're facing this dual challenge. The third archetype, and this applies to many of the countries in Europe where we're standing today, as well as in North America. These are worker advantage countries that relatively have a higher proportion of healthcare workers compared to the other two archetypes, but also still have many healthcare jobs that go unfilled. So countries that belong in this archetype also have to be thinking about how can we improve and increase the productivity of healthcare workers, allowing them to spend time where they need it most, which is with their patients, instead of all the manual and administrative burden tasks that they are dealing with today, which our research shows can take up to 30% of a healthcare worker's time. So I want to switch gears a little bit and now start talking about the solutions at hand. And as I mentioned earlier, we believe that it's really important not just to focus on the supply side, but also on the demand side when it comes to the healthcare worker ecosystem. But let's start with the supply side. And our research has actually collated and found that there are many known interventions today that can be scaled, that are really effective, and that will make a difference. And what difference would that make? By scaling all the known interventions, we would be able to add up to 5.6 million healthcare workers into our ecosystem. We've classified these interventions in 3 types. The first we call grow, which means that we need to expand our training pipeline to make sure that we are constantly building and developing a more qualified talent and a larger talent pool for healthcare workers. The second is thrive. And I've spoken a little about this, but this is really improving the productivity and making sure healthcare workers can spend more times with their patients and through technology become even more efficient. The last is what we call stay. And we think that this is incredibly important because everyone's always talking about how we need to grow the pipeline of healthcare workers, which of course I fully agree with. But there's also really a lot of importance that we have to put on retaining the healthcare workers that we already have in the system. But let's talk about what I'm not saying here and what you've probably looked at the chart and said, hold on, there's something funky here. And that really is the fact that we know that the healthcare worker shortage is going to be at least 10 million workers short by 2030. And scaling all these known interventions will only get us to 5.6. So just solving about half of our problem if we do everything the right way. So what does this mean for us? Let's actually take a step back and ask ourselves, in order to solve this looming crisis that we're facing, we really do need to look at the demand side and how we can completely reimagine the healthcare worker ecosystem. We need to think about who is a healthcare worker of the future? How is healthcare being delivered? And where can we receive healthcare in the future? So I'll dive a little bit deeper and give you a few examples. When it comes to the who, we imagine a world where everyone can be a healthcare worker. Now, this may come with some controversy, but what we're trying to say here is not that we don't need healthcare workers. Of course we do. They are the heartbeat of our healthcare ecosystem. But what we imagine is a world where patients are actually empowered with the knowledge and information to be able to manage their diseases in lower acuity settings, whether that's actually at home or whether it's in their communities. Let's now talk about the how of it all. We imagine a world that patients will find the right care the first time around without spending a bunch of time trying to figure out which specialists, which PCP to go to. And using technology and next-gen AI tools, they will be able to intervene much earlier on in order to manage their disease progression before it advances, and therefore being able to utilize care settings that are much less resource intensive. The last one is really where. And we imagine a world where patients are able to receive healthcare that are embedded in their daily lives. So imagine dropping your kids off to school, imagine going to the grocery or the supermarket, and you're able to get screenings, you're able to get treatment, and you're met with community health resources and workers that can help enable you to receive care and, again, make sure that you're able to have the knowledge to manage the care in much lower acuity settings. This is a world that we imagine that will rely a lot more on primary and preventative care and be able to have our healthcare workers focused on higher acuity, more traditional settings. So before I invite one of our very special guests, Millicent, up on stage, I would like to just leave you with one question. What do you believe a complete reimagination of the healthcare worker ecosystem could look like? And what would it take to make it happen? I also want us to acknowledge that we are in a turbulent time where budgets are being constrained. And we all need to realize that, of course, we could wait for perfect situations, but that will never come. We will require radical collaboration, cross-sector, and we will require everyone across the globe to work together to truly develop solutions and scale them to completely rethink how we deliver care. Thank you so much, everyone. And I would love to invite Millicent up to stage here. Thank you so much, Millicent. Thank you so much, Millicent, for joining us today. Millicent is a community health worker based in Kenya out of the Ministry of Health. And we're really excited to be able to understand her lived experiences today. And I think oftentimes we rattle off facts and figures and we forget that there are people with lived experiences behind all these facts and figures. So that being said, Millicent, would love to hear from you on what you believe in your experience is the most urgent issue to address related to the healthcare worker shortage.
Okay, thank you so much. Good afternoon, everyone. Yeah, I'm Millicent Miruka. I'm a community health worker working from Migori County in Kenya. I'm working under Ministry of Health, and I'm also a Lola-supported community health worker. It's such a great opportunity to be here today as a community health worker who is working in the community. The most urgent issue here is about professionalization, because we need to be trained, we need to be paid fairly, we need to be supervised, and we also need to be recognized by our government. Okay, as a community health worker, I'm a parent, and I'm also a caregiver besides being a community health worker. And so we have other responsibilities. And so when we are not paid fairly as community health workers or as a caregiver who has also a family, we can look on other alternatives for us to cater for our families. And so through doing this, you'll find that our communities will suffer. They will not get the services that we are giving them in the community. Another point here is that we are in the community. And my role as a community health worker is to ensure that all patients who are sick, I should refer them to the facility to get the services. And here comes a case whereby, after referring a client to the facility, you'll find that there is no doctor or a nurse in the facility. So I think, or I believe that the government should play a big role here to ensure that the community health workers are trained, we are supervised, we are equipped to do our roles in the community. Another point here is that the government should also ensure that health facilities, the health providers, should be there enough in the health facilities to serve our communities better. Thank you.
Thank you, Millicent. I think that's very helpful and just echoes the point that, this has to be a collaboration between public sector, private, and many others in order to really advance this issue. Another question we had top of mind was really, maybe you can share a little bit more about how you feel the shortage is impacting you the most.
Okay, thank you so much. The shortage is impacting maternal and child health care. Through saying this, I would like to share with you a short story. In a community where I'm serving, I have pregnant mothers. And now one night, a pregnant mother called me, and she was in a labor. And as a community health worker, I had to go and assist her. So when I accompanied this client to the facility, the nearest facility, I found that there were no doctors, there were no nurses to serve the client. So because my client was in a serious pain, I had to move to the next facility that was quite too far from where we were. There, we were received with healthcare providers, and my client delivered a bouncing baby girl when we reached the facility. So, I want to say that my question, let me just ask a question. What if we didn't find a healthcare provider in that facility? What could happen to my client? Would my client survive? I'll let you answer that question. Thank you.
Thank you so much, Millicent, for sharing your experiences and the impact that this shortage has on community health workers, but also communities far beyond that you are supporting and taking care of. Thank you so much for all of your work.
Thank you so much, Yenli, and thank you again, Millicent, for sharing your experience. I want to welcome our panelists to the stage. First, Dr. Nan Chen, Co-Executive Director at Africa Frontline First. David Entwistle, President and CEO at Stanford Healthcare. Des Teleku, Group Director of Partnerships and External Affairs at AMRETH. And Cynthia Mwase, Director of Africa Health at Gates Foundation. And finally, of course, our moderator, Dr. Marilyn Kimeo, Expert Associate Partner and Co-Director of Health Worker Capacity at McKinsey Health Institute. So please give our panelists a very warm welcome.
Good afternoon, everyone. It's difficult to start a panel after hearing that lived experience and really keeping in mind what could have happened to that mother and child if no healthcare worker was in the facility. So that's the point at which we start our panel today. And I'm very excited to be joined by exceptional leaders from different sectors and with different vantage points into the healthcare worker shortage globally. Welcome to all of you, and thank you very much for joining us.
Great to be here.
Fantastic. So I'd like to start off by just getting your overall perspective on the healthcare worker shortage. And my main question is, what is the one most urgent issue you would advise delegates to focus on in the healthcare worker shortage? And if you could give me the answer in 30 seconds or less. Let's start with you, Desta.
Wow, 30 seconds. Well, I guess earlier I was having a conversation and we talked about how health actually drives the economy. But in many cases, my colleague and I were talking, we said actually the economy is actually driving health because it is what can be absorbed into the health system that often will end up being able to transform the health status. Does that answer?
Fantastic, and in less than 30 seconds. Cynthia.
I don't think I can beat that. I would say two things. Allow me to say two things. The first one is I think we need to become a little bit more sophisticated in how we define the problem because we don't have a health worker shortage. We have a shortage of specific people and specific skills. And unless we disaggregate that, we cannot solve it in a holistic three recommendation thing. And the other thing that I would say that we need to put out there, I think has been indicated, is we don't only have a worker shortage, we have a work crisis. Defining what the work is needs some effort and time. We've moved on, profiles of our countries have changed, and we haven't changed how we profile the worker of the future.
Two great answers. We're going to get a diminishing margin of returns as we get down toward the end with all this great content and knowledge. So if we think about all the challenges, I appreciate what was just teed up because we look at where the market is. We are struggling with economy and cost and labor force, all the things that are driving part of this perspective. So how do we, one, strengthen our current workforce? How do we take those and literally, if you look at the grow, thrive, and stay, those are important principles that come into this. So how do we support those coming in? And hopefully we'll get into some of what I hope will be the technology solutions to some of that. But then how do we enable the workforce that we have now to even go beyond what they're doing, but also we hope to expand on the capabilities and actually create more in as a result of having more of the technology that will help drive them, some of that. So.
Thank you, David. Nan?
All right. In 30 seconds, I don't think a health worker job is that different than any other job. In order to grow the health workforce, we do have to reimagine it, but it is the material conditions of these jobs that get people to be recruited, and to thrive, and to stay. If I'm not going to get paid, I'm not going to stay in my job. If I have a bad supervisor, I will not stay in my job. So I think part of what's the solution here is these promising innovative practices coupled with the pathways to adoption by policy, by programs, and the financing behind them that'll lead to the jobs for today, the jobs for tomorrow.
Thank you very much to all. And I think we're hearing themes that are arising in terms of, economy driving the health workforce, but also how do we help the health workforce we have today thrive? And that's what I'd like to talk about for a moment, David and Nan. And we know that our healthcare workers are really faced with simultaneous pressures of rising demand from patients, but also a large administrative burden. My colleague Yen Lee mentioned that, 30% of nurses' time is being used on administration. And I'd like to understand, what role do you perceive organizations can play to really make sure that healthcare workers are being set up for success in their roles and can actually focus on their core job, which is direct patient care? David.
Let me get started with that then. We'll try to be longer than 30 seconds. No.
I'll give you 1 minute this time.
35, we can't go too long. Well, if we think about the burdens that our folks have, again, in our individual facilities, whether you're talking about your frontline workers, to your hospitalists, to your, again, ICU's intensivist coverage, there's a lot going on right now. Being from Silicon Valley and from Stanford, I will probably focus a little bit more on some of what the tech solutions may be. But I start with the caveat that not everybody starts in the world with the technology that perhaps some of us do or advantage with. So we've got to take all of those things into account as we're thinking about some of the solutions. We have been focused on how do we use the technologies today. We all love to talk about AI, but instead of artificial intelligence, I like to think of it as augmented intelligence. How do we help those that are individuals do the work that they do better? We heard about the administrative burden. There's a lot that we're having to do, whether it's the physician writing a follow-up note, whether it's a summarization of the notes from the session that they had. We're using the, again, chat EHRs to actually collect and create a note outside of what our physicians do. We've also expanded that to the nursing workforce. We'll go on to the respiratory, the occupational, et cetera. How do we get out of getting to the end of the day and having to write or do all of this administrative tasks that takes a lot of what we call our pajama time away? How do we at the same time take the technologies that exist today and are incredibly beneficial and in fact have a high resonance with our providers to actually do the ambient voice listening in the room? We can now summarize, provide draft notes back to the physician, populate the EHR, and in fact write a follow-up note to the patients, all from the technologies that are there. Think about how much that will do as we, again, use some of that technology to offset. I'd go a little farther to say probably technologies that you may already be using. How do we use the telehealth technologies? We now have roughly a third of all of the visits that take place at Stanford, 2.5 million plus, that are now in telemedicine. That has changed since the pandemic. We only had 2% before the pandemic. Providers now are much more apt to do that. We have e-consults that allow platforms from specialists to talk to primary care physicians in the community without ever having to have the patient travel. We've got to look at some of these technologies in a way that actually allow us to support relieve the administrative burden. One last one, which is kind of exciting. We just went live with early discharge home. Imagine patients who could be just a little bit of follow-up and care, but actually be in the home in the setting. We've now been able to actually move those patients out more quickly with the right telehealth and follow-up care in the home, being able to get them out quicker. So a lot of exciting technologies as we think about this.
Thank you, David. And I'll follow up a bit later with how you actually drive the adoption and integration as a last question. So I'll give you a few minutes to think about it. Nan?
Well, I love what you're saying about the role of technology, and where I would maybe just to build off those ideas, I think technology can be a real driver of this kind of change. We want to be careful that, as you said, David, technology augments health workers as opposed to eroding like the fundamental dignity of this workforce. And when we think, I love Yen Li's big question to us, how do we reimagine? The future looks like more local and decentralized workers, that the care that people are provided is personal and preventive, and that digital has a huge role to play. Now, what I would typically add to this conversation is we always need to come back to the dignity of work. What Millicent was sharing with us earlier, if we're not paid, if we are not supervised, if we do not have the resources and supplies to thrive and do our work well, we may have decentralized services, but we will not have a workforce. And one of the ways that we can, so at Africa Frontline First, we've been working with governments for quite a while to try to address this challenge. One of our big results from the last year is we've been able to support directly 68,000 community health workers across Africa. That's a community health worker that has been trained, that has been paid, that has been provided supervision. And part of why that's possible is not because we're not doing it alone, certainly. It's with the doers, the implementing partners, the governments, and the funders, all reading off the same playbook to fundamentally improve the material conditions of a health worker. And so as we think about the future, how do health workers thrive, get excited for all the things that can be coming with either digital technology or decentralized care, and remember the fundamental pillar of dignity that must remain for us to be successful.
Thank you very much, Nan. And I love that theme about, keeping the dignity of the healthcare worker at the center, and really how we think about technology influencing that. There's a common theme that keeps coming up in terms of training, and training is one of the ways you ensure healthcare workers have dignified, dignity in their jobs. But also we see that training currently is really not meeting the demands of the healthcare workforce, either from a capacity or a scale perspective or a quality perspective. Cynthia, you mentioned, our healthcare workers equipped for their job of today. And I'd like to hear from you, Cynthia and Desta, how we really transform training to make sure that the healthcare worker we produce is ready for the ecosystem that they're released into. Desta, let's start with you.
Thank you. And actually, I liked what you said, Cynthia, earlier. People I mean, AMREF trains, we've been doing this for 7 decades, so we're not new to the job. And we understand what communities need, how to work closely with communities. So when I was listening to what Millicent said, she deals with a whole different landscape than you do, in the US or in any other country. We're dealing with communities that have very specific needs. And so the training has to also align with that. So when we think about what does Millicent need to know, not only does she need to know X, but she also needs to understand what the community, the context in which the community that she serves lives in. So if we are training for whether it's nutrition or anything else, we need to understand what the people in that community value most and then train accordingly. So it's not just training, what they need to know, but it's also looking at the context in which they actually operate and provide appropriate training. That's number one. Number two is the issue of compensation. Many times in many countries, community health workers, and we work with community health workers, are not necessarily paid. They're valued in the community, but they're not appropriately compensated. And most community health workers are women. And therefore, they face this additional burden of not being paid, but doing God's work at their own time, at the expense of their own family time. So I think we need to look at not just, context, but also whom we're looking at. We have to look at the economy. Can we pay these people? Do they understand the community? And so there's a lot more that goes into training for community health workers. And they are the first point of contact for most people in our countries to the formal health system. And so if they're able to do their work, if they are actually enabled to do what they need to do, many more people wouldn't necessarily need to have emergency care, right? We can provide the right type of intervention. We can provide, training on how they can access the health system earlier so that it's not an emergency. So I think not just quantity, but quality. Who do we need? We need community health centers at the front line. And then when we look at also, there was a ratio, I think, that was shared earlier, the ratio of healthcare workers versus, what we need. But we have to look beyond numbers. You can have 100 health providers, you can have 100 surgeons and not have 100 surgeries to perform, right? Do you need pediatricians? I mean, if we're talking about, more beyond community-based health worker, if you're looking at other health providers, what do we need? Do we need dermatologists? That many? Do we need surgeons? That many? Like, who do we need? And I think it's really important for countries also to contextualize their need. What kind of health workforce do we need? Can we absorb them do we have the appropriate training, capacity to train them? And if we do, can we absorb them into the system? Have we ring-fenced funding to be able to afford those people? In today's environment, we're going through a medic crisis. We have to really look at what's important for us in terms of health workforce and really focus and zone in. Everything may be a necessity, but what's the priority? And given the space that we're in most African countries, the space that we're in, we really need to now think about, do we need to reevaluate? Is it prevention that's important? Should we start focusing on that in terms of training, or are we still going to do specialized training? So I think we need to look at not just numbers and ratios, but what kind of health professionals we need at the professional level. And then at the community level, are we providing the right type of supportive environment? Are we ring fencing funding so that we can actually pay them, because they are doing the work that actually prevents people from having to go to hospitals to begin with.
Thank you very much, Desta. Cynthia? Yes, I think that deserves a clap.
So I just want to state right off the bat that I don't have the answer. But I have some thoughts. The first thought is, I'm thinking about the grants that are signed or have been signed in the past by funders who have wanted to be supportive in the area of training health professionals. And it has always made me think, it's it's a very expensive budget line because it has always ranged from about $4 million a year, and this is for one vertical program, to $20 million a year to train doctors, nurses on the new diagnostic tools, a new way of doing things. So I have lots of questions about why is it costing so much? Why isn't this part of the core training at the beginning? What is it that we need to get people continuously out of their daily jobs to go back and train and retrain in every year, in every grant? And I'm thinking about the whole range of health workers. The second thing that I'm thinking about is a while ago, Kenya did a study to understand absenteeism. And the findings were that the largest part of the absenteeism was actually authorized absenteeism due to trainings across the board. This is on, you can Google the document, it's there on the internet. So again, it makes me think that training it's like an onion. We need to unravel what the challenge is, because the challenge is not only we need people to be better trained. I think we need to write a whole page of a problem statement around what is the problem with training. Then I'm thinking about training also in the way that we've been doing it. We take people must be in the classroom and then go to the world of work. While they're in the world of work, they must leave to go back into the classroom to go and be trained. But we all know that training happens in different ways. So maybe we need to reimagine the places in which we are getting trained. I was very fascinated that when we had COVID, I observed some of the labs that emerged at that time to test for COVID, because people needed COVID tests to travel, so there was a lot of mushrooming of places where you could have your tests. And many of those places were training the people in their little lab every day, because there were new guidelines. They needed to submit their daily account of negatives and positives to the Ministry of Health. So all of that was happening, and they were doing it at the end of the day. They would close the lab like an hour or two before to the public, and they would sit down and do some training. So that was a different way of training for the need. And that's just, those are the things that are in my mind, that we have not challenged ourselves enough, looked at the context and said, we need to rethink this. We don't have the money to train the way we've done in the past. We need different people, but we need to think differently and more innovatively in terms of how. So I don't have the answer, but those things are in my mind.
Thank you both for sharing that. And I think key things there is really contextualizing training, right, to who you're training the healthcare worker to treat, but also really rethinking how we accelerate training and make it lower cost. And we do see some solutions exist. And I'd really like to pick up on, Desta, what you shared in terms of absorbing healthcare workers, right, and particularly this issue of retention and making sure healthcare workers stay. And we do see in many low and middle income countries, we have a paradox where, for example, in Africa, as you mentioned, we have a large shortage, 6.1 million healthcare workers. But at the same time, only 1 in 3 healthcare workers who are trained are actually employed. And it is a big issue. We cannot talk about training and increasing supply if these people do not have jobs to go into. So I'd like to get your perspectives, Nan and Desta. And Desta, I'll start with you again, just given you had picked up on this in your last statement. How do we build partnerships across multiple stakeholders that can really be structured around creating sustainable talent pipelines that can both be trained and absorbed?
That's not easy. But what I will say is the training has to be aligned with the need. What is the need of the country? Just nationally, what is the need? At the community level, what is the need? Has the government prioritized that? It's not just, there is a need in everything, isn't it? We can always find need somewhere. But where is the need? Where is the gap? Has the government prioritized it? Because they have to absorb this health workforce. Unless we're training for, diaspora, to go. But on continent, in country, we have to train for what we need. And we need many things. What's the shortage? You just gave the number. 6.1 million is the shortage. Are we going to be able to pay for all of them? No, we can't. And therefore, we have to work with governments to understand what that gap is that is a priority. Not just the gap in general, but what is the priority for that country, and focus on that first. There are many partnerships that we have had, and I don't know if I can do this, but I'll just name one, for example. We had a partnership with GSK for many, many years, and GSK was a corporate partner that said, X% of our net profits that are made on this continent will go towards training health workers, right? So when you have that kind of reserve, you can train health workers and actually absorb them into your system. But if you don't, then the treasury has to decide that this is a priority. And that's why I said, we have to look at prevention in today's environment. We need to look at prevention. We have, the mean age of Africa is 19. We're not dealing with the kind of population challenge that Europe is having. We have a very young population, and we have an aging population, and we have a situation in which we are facing health issues in a quantity that we probably cannot handle. We have NCDs coming up, all sorts of things, and we have to think about what is our need now and adjust that investment that we make or the commitment to absorb that we make based on our populations and based on what we can afford to do now. And so I think that's what we need to work with countries and say, what is your biggest crisis? There is urbanization. There's a whole bunch of health system issues that we need to look at, right? There's the crisis that we're experiencing with climate, with population, with rapid urbanization. Everything comes with a cost. And therefore, we have to work very closely. National governments, let them prioritize what's important for them. Let's train to that need first and fill that gap and make sure that countries can ring-fence funding to pay these people.
Thank you very much, Dasta. I also heard in your example the role of private sector. So especially in our constrained environments, it's an interesting aspect to really consider and drive. Nan, would love to hear your perspectives on this.
I love this question because it helps us take a step back. The crisis we're in is not simply, as you said, a crisis of a shortage of health workforce. It's that we also have a big shortage in systems that can actually absorb those workers. And if we don't do this right, if we don't do this well, what we're going to do is end up training a bunch of health workers for jobs that don't exist while their patients, while the clients like Millicent's client are waiting, dying at a clinic, waiting for care. So we could really get the balance wrong here. The stakes are quite high. When I think about what's the purpose of training, so we've been talking about training a lot today, and Cynthia, you were talking, why are we doing all this training? If I'm a health worker, if I'm a community health worker, at the end of a training, I don't want to get a t-shirt or a hat. I want a career. I want a career that can support me and my family for, thank you. And so the question I think you're asking is, how do we build careers? So training is important. We want, and specific specialized training, but the other two pillars that I've seen really are, we need political commitment, policies, pathways to adoption and absorption, and the financing that allows for health workers to be absorbed. I agree, Cynthia. We don't have all the answers, right? But I bet there are little pockets of answers in this room. You've seen some of them, Cynthia. I think, David, you were talking about AI earlier. I saw in Ethiopia, the health extension worker program there is using blended learning, digital blended learning, to reduce the cost of training substantially. And I think they just added an AI call center, right? So there's ways to reimagine this. I think the future is here, but it's unevenly distributed. And part of the job, part of the solution is figuring out how to identify and distribute out. If I had a magic wand, which I don't, but if we do, I would love to see a program and an initiative that identifies and demonstrates these promising practices with a learning platform. It helps bring the regional initiatives that help to bring training standards, certification, maybe even CHW or health worker associations together as well, and then brings the financing, the catalytic funding together to bring that all together. Practices, pathways to adoption, and financing to support it. I think that could really get the engine going.
Thank you very much, Nan. There's an element of having to create an ecosystem. Desta, please go ahead.
Sorry, let me just add something. And I'm sorry, I don't have to leave. But what I wanted to add was there are some countries that are already absorbing, for example, community health centers into the formal health system, right? So you have countries like Ethiopia, where community health workers are sort of the first level of health workers, and they actually enter the system from there. And there are different cadres of health workers. So I think countries can be very creative, and maybe they just need support from whether it's private sector or foundations, just a little support to figure out how do they actually embed community-based health workers into their formal, health workforce.
Integrate them into the health system. Thank you very much, Desta. We will have to excuse Desta in classic WHA fashion. She has multiple events that she's representing AMREF on. Thank you very much for your presence. So I'd like to close out the themes that we've discussed going back to technology, David. And I think you mentioned multiple innovations that can really help healthcare workers thrive, but also improve quality of care. And technology at best has been really adopted unevenly, especially when we think about LMICs, but even in developed countries. And I'd like to just hear from yourself and Cynthia what we can do to really drive technology adoption and integration in a way that really serves both the patient and the healthcare worker. David, let's start with you.
Okay. Thank you. And again, all technology, though, is about priority. And I love the piece about what's the priority. If I was in Africa with hearing from Millicent, my priority would be let's get the healthcare workers paid. So if we look at how we adopt technology, let's start with that framework around what's the priority. I like what Nan was just sharing. How do we scale the technologies that actually can help with some of these individual problems? As you look at technology, though, and with that caveat, and again, depending on where you are in your own country, where you are in your own evolution with that, looking at the technology and the ability it has to scale, you have to first of all start with how ready is your workforce for this? Let me just do a little bit of a show of hands. How many of you have used some sort of AI? This could be a Gen AI, so you're using it to draft a note. It could be agentic AI, where it actually uses a chatbot you've called into a line to help. How many of you have had that opportunity to use AI in your own lives? Okay. How many of you use that on a monthly basis? Okay. Weekly basis, daily basis. So pretty much all hands are raised. So this is a tech-savvy audience. I love that. I bring that caveat because we actually wanted to start at Stanford to say, where is our workforce at now? Because who has a little bit of anxiety? Who has a little bit of nervousness about what AI will do? Obviously not this audience. You're using it on a daily basis. So it's not going to replace you. You know that right now. So the reality is, if you look at our workforce, and we started this actually looking at a couple different academic medical centers within the US, we looked at the population of who is using it on the frequency that you were. Now, granted, this survey was about 9 months ago, but we only found about 11% of the population that you just raised your hand to were actually using this on a daily basis. Interesting. Think about how fast this technology is scaling. Now, again, I'm not giving an advertisement for Microsoft, but Copilot right now allows you to do that as you're drafting a note. In fact, it's kind of shows you how excited my weekend was last. Have you ever played with Gen Emoji? So you can now generate your own emoji based on the feeling that you have right now. Okay, I was kind of bored, but it was an exciting thing. We think about where this technology is heading. Now, of our physician workforce, however, 49% was actually using it. Now, only a third of those, sorry, let me go back, caveat of the 11% of those that were actually using it more frequently, about half of that among the physician group was using it, which is pretty good. I think they're using it, whether it's to draft notes, whether it's using the ambient voice. Only about a third of our other population of healthcare workers was using it. I will tell you, some people are fearful that AI will take their job away. I don't think that AI will take our physician workforce labor away. It doesn't have the ability to multimodal, think through, and provide the opportunities that our physicians can to draw. Now, pushing that concept a little bit further, what about AGI? So AGI is a concept that actually you would have artificial general intelligence. There's some folks who feel that that will be available as low as 3 years from now. Think about a technology that can learn, understand, and act. That's what AGI. Now, some say 3 years, some say 25 years, so we're safe for a little bit of time. There's a wide range in there. But where is this technology evolving to? How do we use it in such a way that will actually be able to augment what we're doing, but also be able to transition some of the things that we're working for us in doing? Now, how does that scale? That's why I started with that perspective. If you're in a clinic that can't get staff, that's going to be different to think that you actually have the technology to employ this. How do we get our workforce, however, ready for that and accepting of what those new technologies might be, maybe the harder task?
Thank you, David. And Cynthia, over to you. I would particularly like to hear the LMIC context for this.
Okay. And I saw the note that we are over. So I'm just going to list stuff. The first thing is to say that with tech, okay, let me go with first. There are some technologies that we will need to adopt. We're excited about everything that's coming. We don't yet have the infrastructure. Unlike supply chains, like buying of commodities and procurements, we've mastered the art of product introduction. We haven't yet pinned down the art of adopting tools that are coming out. You know, we don't understand regulatory pathways, who approves what. So we are constantly in the mode of piloting and doing small things, to your point, Nan. So that's one thing that we need to figure out before we say, here's how we enable people to use tech. The second thing is we do have some great tools out there that I want to make a pitch for. We have AI-enabled ultrasound machines. We have things that we can put in people's hands, and we need to make sure that those things get into people's hands. The last thing that I will say about tech, which is interesting, is that it is very interesting and we can get drawn in it. But I would encourage the innovators to also innovate for the user. We innovate for the problem, the health problem. We innovate to get around the system, but we don't think about the user. And I brought a prop with me today because I got this when I registered and then I was going to wear it. And then if you look at it, it doesn't work for my dress. I have to go to the bathroom to go and wear this. So the intention was great, but it doesn't work for the user.
User-centric innovation. The message is loud and clear. Okay, given we're out of time, I do want to thank you for sharing your experiences. I think we do have a journey ahead of us in closing the shortage, but there are some bright sparks that you have all shared that could, drive really towards impact. I do want to give you each 10 seconds. If you could give this room, the delegates in this room, a call to action, right? What is the one big program that you'd want to dedicate your time to really close the shortage?
I can't do it in 10 seconds, but I can tell you that the foundation is working with 11 countries to help them rethink and redesign their health service delivery, given the changes in the landscape. So all the skills and all the advice that we can tap into, we're open to introducing you to countries, and we would like you to also nudge the countries because you have the relationships with them.
Fantastic. So driving partnerships from Cynthia. David?
Prioritize those things that are important to your organization. Don't get lost in all of the shiny things that are out there, and prioritize what works for your team and your staff. The most important part of the grow, thrive, and stay is the thrive. How do we get and support our workforce that's in the workforce now to get them to be able to stay and thrive in it?
Thank you very much. Nan?
the future is unwritten. The choices that we all make today, that you will all make daily, will define whether we are in a future where there is a healthy workforce that is digitized, personalized, decentralized, and dignified, or if we're in a much worse place. But it's all unwritten. It's all up to the decisions we all make.
Thank you very much. Over to you, Ali.
Thank you. Thank you to our panelists and to Marilyn for guiding what has been a truly compelling conversation so far. I just want to take a moment to say goodbye to our online audience. We're going to conclude the live stream portion.